بسم الله الرحمن الرحيم. الحمد لله رب العالمين، والصلاة والسلام على أشرف المرسلين سيدنا محمد وعلى آله وصحبه وسلم أجمعين. سبحانك لا علم لنا إلا ما علمتنا إنك أنت العليم الحكيم. Dear colleagues, this is the continuation of the sector of MR imaging of the knee joint, and we have finished two parts of this section, and we discussed the normal anatomy, the examination techniques. Also, we finished the meniscal pathology, and in the second part we discussed the injuries of the ligaments. Then in this part we'll discuss the remaining issues in the knee joint, which include the evaluation of the patellar and the quadriceps tendons, also the patellar lesions, synovial pathology, osteochondral and bone marrow lesions. Starting by the evaluation of the patellar and the quadriceps tendon, we have these issues. Number one, a complete tear, partial tear, acute tendinitis and chronic tendinitis, and finally Osgood-Schlatter disease. You know that the quadriceps tendon is a strong tendon which is attached to the upper wall of the patella, and the patellar tendon is its continuation to the tibial tuberosity below the level of the patella. In some books, it is usually stated that the quadriceps tendon should not include any abnormal signal inside its substance. But frequently you can see these lines which may represent some fat inside the tendon, and they are considered normal. Then injuries of the tendon may be in the form of complete rupture or partial tear. And the complete rupture usually affects the tendon near its patellar attachment, and it occurs in usually in young athletes. The rupture of the tendon will interrupt the low signal parenchyma of the tendon itself, with the presence of fluid signal intensity at the site of the tear. Then axial images are important to differentiate complete from partial tears, while the tendon tear is usually evaluated in the sagittal image, as you can see here. Then one of the important issues of any tendon rupture is to assess for the state of the muscle of belonging to this tendon, because the surgical repair of the tendon depends very much on the state of the muscle. If the muscle is atrophic, then tendon repair will be somewhat useless. But if the muscle bulk is maintained, then there is a good possibility for repair of the tendon and re-achievement of the muscle function. This is an example of a rupture of the quadriceps tendon near its patellar insertion, with the interruption of its fibers and the fluid signal intensity at the site of the tear. And here we have to say that some tendons in the body are not ruptured spontaneously. I will mention this whenever it comes in certain joints. But this is one of the tendons which can rupture due to trauma and can show rupture without significant history of trauma. And an underlying systemic disease is usually present, and these are the possible causes or the possible diseases, including systemic lupus erythematosus, gout, chronic renal failure, rheumatoid arthritis, hyperparathyroidism, and diabetes mellitus. In the axial image, you can see the contour of the tendon. If it is partially torn, and you can see some of the fibers are maintaining their normal low signal intensity, other fibers are torn. And this is somewhat difficult to be evaluated in the sagittal image, but in the axial image, you can evaluate this. Also, you can see the soft tissue edema and contusion surrounding the tendon. Another example of quadriceps tendon rupture, and at its usual site, which is the attachment to the upper ball of the patella. Of course, you know, if it is post-traumatic, and rupture will lead to a significant amount of blood within the joint, and the patella will be more freely mobile compared to the state whenever the tendon is intact. Complete tear is usually required to be repaired within the first 48 hours if this is a possible thing. Then if the tendon is swollen, as you can see, and there is an extensive intermediate signal within the tendon in the T1 and in the T2 weighted images, then you may consider the possibility of tendinosis or some degenerative changes in the tendon itself. Then, but the patellar tendon is also subjected to traumatic injuries. It is usually ruptured also near its attachment to the inferior ball of the patella. And you see the site of discontinuity of the tendon, which contains a lot of fluid signal, and also you see the changes in the parenchymal signal of the tendon itself. The tendon will be lax with fluid signal at the site of the tear, diffuse tendon thickening if an underlying tendinitis was present. As I will say, you know that tendinitis of the patellar, of the infrapatellar tendon is a frequent finding in the clinical practice, and this may result by time into patellar tendon rupture. Because of the intimate relation of the patellar retinacula to the quadriceps and the infrapatellar tendon, sometimes injury of one of the quadriceps or the infrapatellar tendon may be associated with rupture of one of the patellar retinacula. Here you can see in this example that the lateral retinaculum is intact, identified by the long articular surface of the patella. The short articular surface of the patella is towards the medial side of the knee, and you cannot identify the medial patellar retinacula. Its site is replaced by fluid signal, denoting its rupture. And here is an example of a patellar tendon rupture in this particular area, and you can see the wavy and lax appearance, or you may say retraction of the tendon, and the presence of fluid signal at the site of the rupture, as well as bone marrow edema near the area. Then you know that rupture of the infrapatellar tendon may also complicate local injection of corticosteroids near the inferior ball of the patella as a treatment for patellar tendinitis, which is known as the jumper's knee, as I will say in a moment. This is an example of rupture of the mid portion of the infrapatellar tendon with a swelling of the tendon, diffuse increase of its parenchymal signal intensity, and the fluid signal which is seen at the site of the rupture. You can appreciate this if you compare the torn tendon with the normal appearance of the infrapatellar tendon, which is here is intact, surrounded by fat, and showing normal appearance. Abnormal signal, which may be considered as the intermediate signal in the infrapatellar tendon, which is usually seen near its attachment to the patella, means that there is acute patellar tendonitis, and this is known frequently as jumper's knee because of its relation to jumping sports. And this is a diagram showing the common site of abnormal signal within the patellar tendon, indicating the patellar tendonitis. Then the presence of intermediate signal near in the patellar tendon, near its patellar attachment, indicates acute patellar tendonitis. But if you see that the patellar tendon is diffusely thickened along its whole course, maintaining its normal signal intensity, then you can call this chronic patellar tendonitis. There is no abnormal signal within the thickened infrapatellar tendon in chronic cases. This is also an example. You see the infrapatellar tendon is diffusely thickened and swollen, but in the T1 weighted image it shows some intermediate signal intensity, but here you can see the dark signal of the tendon itself. We came to Osgood-Schlatter disease, which is an osteonecrosis of the tibial tuberosity, and this is the sequelae of repeated micro trauma, usually in adolescence. And the patient usually complains of pain and maybe swelling and tenderness related to the tibial tuberosity. As you all know that most of the vascular necrosis or osteonecrosis at different sites in the musculoskeletal system usually manifests by bone sclerosis, fragmentation, collapse of the affected part of the bone. And here you can see that the tibial tuberosity is fragmented, and you can see some reactive bone sclerosis in the fragments. Also, this is an example by plain X-ray of Osgood-Schlatter disease. You can appreciate the age of the patient from the non-closure of the epiphysis. You can see swelling at the site of the tibial tuberosity, some fragmentation, and bone sclerosis. MRI of the patients with Osgood-Schlatter disease will show early in the disease you can see some bone marrow edema at the site of the tibial tuberosity, and you can also see some fluid signal between the tibia and the infrapatellar tendon. You know that this disease is usually unilateral, but bilateral lesions can occur in 25 up to 50% of cases. These lesions are common in boys than girls, and the most likely age instance is around 10 to 15 years old. Then later MRI will show some changes seen in the plain X-ray. Here you can see the sclerosis and the fragmentation. Also in the MRI you can see some bone fragments, and you can see also some changes in the infrapatellar tendon as well. And this is an example of Osgood-Schlatter disease. Here you see irregularity and some fragments of the tibial tuberosity, fluid signal between the tibia and the infrapatellar tendon, and you see some signal changes in the near the insertion of the infrapatellar tendon into the tibial tuberosity. Then we came to the patellar lesions, and we will discuss the patella alta, patella baja, chondromalacia patella, lateral pressure syndrome, and the prepatellar bursitis. What do we mean by patella alta? We mean that it is displaced upward more than normal, and there are multiple attempts for some measurements related to the patella, the distance between the inferior pole of the patella and the articular surface of the tibia, the length of the infrapatellar tendon compared to the length of the patella. All are aiming to make some rules for accurate diagnosis of patella alta that is upward displaced compared to the normal position. This is one of the ways where you can measure the length of the patella and measure the length of the infrapatellar tendon. This infrapatellar tendon is in normal ranges will be 1.3 the length of the patella itself. Then if you see that this tendon is 1.3 of the patellar length, and this is normal location of the patella, but if it is elongated, meaning that this tendon is twice the length of the patella, and this will mean that the patella has been displaced upward, meaning that it is patella alta. And you should know that any abnormal position of the patella, whether it is displaced up or down or laterally, then this will affect the mechanics of the patella and will help in or will increase the rate of degeneration of the patellar articular cartilage and the development of chondromalacia. And patella vaga, meaning that the patella is inferiorly displaced and the infrapatellar tendon is short, as you can see here. If you compare the length of the patella by the length of the infrapatellar tendon, then you can see that both are equal. But in normal conditions, this tendon will be 1.3 the length of the patella itself. This condition is seen commonly in poliomyelitis, in some cases of achondroplasia, and also in some cases of juvenile rheumatoid arthritis. You can also appreciate the position of the patella, the abnormal position of the patella in the plain X-ray. This patella should be here, but in this X-ray it is inferiorly displaced. This is patella vaga, and you can see the patella is displaced inferiorly opposite the articular surface of the knee. The infrapatellar tendon is short, and you can see some loose bodies within the joint representing this disease, which we will discuss, known as osteochondromatosis. Bipartite patella means that the patella is composed of two parts, and very frequently this may be mistaken as fracture of the patella. But if you look carefully, you can see that this is the full blown picture of the normal patella. There is no missing parts in the patella itself. Then this part is additional and is separated from the patella itself by a well-defined cortex. There is no history of trauma, and there are no signs of trauma, meaning that there is no soft tissue contusion or bone marrow edema or hemorrhage like in cases of traumatic fracture of the patella. And this is the normal patellar articular cartilage, and you remember that this is the medial aspect of the patella and this is the lateral aspect of the patella. The articular cartilage contains water. It will appear dark in the T1 weighted image and bright in the T2 weighted image. Degeneration of the patellar articular cartilage is known as chondromalacia patella. And chondromalacia patella passes through different stages, starting from early changes in the cartilage, ending by degeneration of the patella of the patellar bone itself. And whenever you see irregularity of the articular surface of the patella, sclerosis, and some defects what's known as osteochondral ulcers, then you know that this is an advanced case of chondromalacia patella. And I advise you, don't evaluate the chondromalacia patella in the sagittal images of MRI. The axial images are very good and essential for evaluation of the patellar articular cartilage. And these are the stages of chondromalacia patella. In the first stage, you see only fissures within the articular cartilage, which is maintaining its normal thickness and signal intensity. In the second stage, you see some loss of the thickness of the articular cartilage. In stage 3, you see total loss of the patellar articular cartilage. In stage 4, you see total loss of the patellar articular cartilage with reactive bony changes in the patella itself, including edema, subchondral cysts, and bone sclerosis. These are the changes of chondromalacia patella. One of the very helpful pulse sequences in MRI for evaluation of the articular cartilage anywhere in the body is known as magnetization transfer. This magnetization transfer takes about, let's say, 7 minutes to be performed, but it's very helpful to show accurately the articular cartilage of the patella, of the femur, of the tibia, and so on. And this is the T2 star. You can appreciate this fissure within the articular cartilage on the medial articular surface, diagnostic of early chondromalacia patella. Don't evaluate the chondromalacia patella in the sagittal images. The axial images are essential for evaluation. You can see this fissure, which is diagnostic of early stages of chondromalacia patella. But if you see bony changes, and there is, of course, total loss of the articular cartilage. This area, you can see the articular cartilage, but here you cannot see the articular cartilage, as well as bone marrow edema within the patella, diagnostic of an advanced stage of chondromalacia patella. And this is also an advanced stage with almost total loss of the patellar articular cartilage, cystic changes in the patella itself. And lateral pressure syndrome means that the patella has been displaced laterally away from the intercondylar notch. And you remember, any abnormal displacement of the patella will affect the articular cartilage and facilitates the development of chondromalacia patella. And in the axial images, normally you see the patella is fitting within the intercondylar notch of the femur. But in cases of lateral pressure syndrome, you see the patella is displaced laterally, as you can see in this particular example. And sometimes you can appreciate this in the sagittal images. Normally, you see the patella in the intercondylar notch at the level in the articular surface of the femur, at the level of the intercondylar notch where the cruciate ligaments are present. But in this example, you see that the patella is present on the lateral aspect of the knee, where you can see the body of the lateral meniscus and the fibula. And this is not normal. The patella should be in this midline image, of course. Then if you have the axial image, which will facilitate the diagnosis, and you can see that the patella has been displaced laterally, and you also are able to evaluate the articular cartilage of the patella for any early changes of chondromalacia. And here also you can see the patella, which is present at the level of the lateral meniscus. And in the axial image, you can see the patella is displaced laterally, but the articular cartilage is intact. Then Patella vaga or alta may be associated with lateral displacement of the patella. As you can see in the previous example, this is the somewhat patella alta. You see the length of the infrapatellar tendon, and this is patella vaga, and you see the shortening of the infrapatellar tendon with minimal displacement of the patella to the lateral side. Prepatellar bursitis, meaning that inflammation of the subcutaneous prepatellar bursa, then it will accumulate fluid. You can see this in the sagittal images, and also you can see this in the axial images. And sometimes this is known as housemaid knee, but inflammation of the prepatellar tendon, prepatellar bursa, can be also seen in cases of rheumatoid arthritis. This is an example. You see significant amount of fluid of low signal in the T1, intermediate signal in the T2, and the proton density high signal in the T2, and you can appreciate it also in the axial image. Then we came to the synovial lesions, and we want to have some knowledge about the synovial effusion, lipohemarthrosis, synovial cysts, loose bodies, osteochondromatosis, pigmented villonodular synovitis, synovial sarcoma, synovial lipoma, and synovial lichen. Starting by the effusion, knee effusion is usually diagnosed clinically by pressing the patella against the femur, and you can appreciate the swelling of the knee. But if you have this view, which is known as the cross table view or lateral view with horizontal beam, then you see that the patella is slightly elevated from the articular surface of the femur, and you can also appreciate the distension of the suprapatellar bursa and the loss of the normal fat. You see this infrapatellar fat, and there is also suprapatellar fat which has been obliterated by the presence of fluid. But you can see this effusion by CT and MRI, and in MRI the effusion will be of intermediate signal in the proton density images and of high signal, of course, in the T2 weighted images. In cases of trauma, there may be hemorrhage inside the joint, and if you use the horizontal beam, you can have this appearance, which is known as FBI sign, meaning that fat blood interface. And fat blood interface, you can see fat, and you can see fluid level and the dependent portion. Of course, you may say that this may be fluid or maybe blood. In cases of trauma, there may be joint effusion or maybe hemarthrosis. But sometimes if you look to the density of the fluid, you may suspect that this may be blood rather than effusion. And this is lipohemarthrosis by CT. You see the fat fluid level or the fat blood interface within the suprapatellar area. Popliteal cyst is known also as Baker's cyst and also known as gastrocnemius semimembranosus cyst, and this is a collection of synovial fluid within the popliteal fossa, and it shows the same signal intensity similar to the synovial fluid, being of low signal in the T1, high signal in the T2, and very frequently you can see this projection between the gastrocnemius and the semimembranosus muscles. This is also a popliteal cyst showing internal septation in a case of post-traumatic vertical tear of the posterior horn of the medial meniscus. Loose bodies are most commonly the sequelae of osteoarthritis, but in the beginning era of MRI, we used to read the MR examinations of any joint together with the plain film of the same joint in order to avoid some of the common mistakes, like misinterpreting loose bodies as any other pathology, or to miss the diagnosis of one of these loose bodies. Loose bodies, being of cortical bone, will appear black in all pulse sequences, and they will appear dense in the CT images. As you can see here, multiple radio opaque or calcified loose bodies within the posterior compartment of the knee, and also you can appreciate that the presence of joint effusion in both cases, here by CT and here by MRI. In osteoarthritis, you got the usual manifestations in the knee, and as every large joint and any large joint in the body, these manifestations will include certain pathologic entities. One of them is the development of loose bodies. And you should know that if the loose body is large, it will develop a marrow cavity, and it will show the same signal intensity similar to the femur and the tibia. Osteoarthritis of the knee will manifest by narrowing of the joint space, osteophytic clipping of the articular surfaces, subarticular bone sclerosis, subcortical pseudocystic changes, and bone marrow edema of the opposing surfaces of the articulating bones, loose bodies due to fractures of the osteophytes, interarticular air or gas due to degeneration of the cartilage. And degeneration of the cartilage is one of the common manifestations of osteoarthritis, especially in advanced cases. And here you can see an arthroscopic picture or cadaveric picture where you can appreciate what do we mean by degeneration of the cartilage, or the commonly written word in the report, denudation of the articular cartilage. Denudation meaning that the cartilage is totally degenerated with loss of its normal thickness, loss of the water content, ulcerated surfaces, and these ulcers may reach the underlying bone. And here you can see this is the articular cartilage of the femoral condyle, which has been totally lost here, and the result is the development of multiple subarticular pseudocystic changes, which are common in severe cases of osteoarthritis. Also, you can appreciate the prominent osteophytes. You can also see the bone marrow edema of the articulating surfaces. Here you can see in the tibia more than in the femur. Also, you see the degeneration of the menisci. Here's the anterior horn of the medial meniscus, which is more or less intact, but there is almost total degeneration of the posterior horn of the meniscus. This is also a case of advanced osteoarthritis of the knee, with a severe loss of the articular cartilage, narrowing of the joint space, subarticular bone sclerosis, and some subcortical pseudocystic changes, together with osteophytes and meniscal degeneration, as you can see. Synovial osteochondromatosis means that there are a lot of loose bodies within the joint, and these loose bodies will result from synovial metaplasia into cartilage. Then cartilage will calcify, leading to many intra-articular loose bodies. The presence of these loose bodies may cause widening of the joint space and may result in bone erosive changes, and will accelerate the development of osteoarthritis. This synovial metaplasia will result in cartilage formation, and cartilage will later on calcify. The lesions are common in the knee, hip, and elbow, and this is the age incidence and the sex incidence as well. Loose bodies will appear dense, and the CT scan will appear black, in the MRI T1, T2, and the STEER images. This is an X-ray of the knee showing numerous loose bodies in the lateral compartment as well as in the suprapatellar bursa. An extensive case or extensive loose bodies within the knee joint. You see all these are loose bodies representing a case of synovial osteochondromatosis. Pigmented villonodular synovitis is a disease of unknown etiology. It is a monoarticular pathology. It will result in synovial masses containing pigments, so they will appear of dark signal in the T2 weighted images. Typical location of pigmented villonodular synovitis is in the hofsbad of fat. This is almost a typical location of pigmented villonodular synovitis. You got hyperplastic synovium, and you got effusion, which may contain blood, and also in advanced cases you can see bone erosions. And one of the important issues for the diagnosis of pigmented villonodular synovitis is the detection of multiple intra-articular synovial masses that are most likely black in the T1, but they should be black in the T2 weighted images. And if you inject contrast media, the lesions will show enhancement. And here is an example. You see low signal lesions in the posterior compartment of the knee as well as anteriorly, and after contrast injection you can see enhancement of the lesions. As I have said, in advanced cases of pigmented villonodular synovitis, you got erosive changes of the articular surface, and you can see these very well defined erosive changes in the femur and in the tibia, with distension of the joint capsule, relative increased density of the soft tissues within and around the knee joint, and you may feel that there is some calcification or what seems to be calcium, and then you suspect that this is pigmented villonodular synovitis. Then if you have MRI, you can see the masses which are very dark in the T2 weighted image. They are also dark in the T1 weighted image, and you can appreciate the erosive changes in the adjacent bones. This is also a case of pigmented villonodular synovitis T1 with T2 weighted image. All these are T2 weighted images, and you can see the extensive synovial masses of dark signal in all images. And synovial lipoma means that you got a fatty or fat containing mass within the joint. And you can see here this is a big lipoma within the anterior compartment of the knee. And you know lipoma is made of fat, and fat will have the same bulk sequence similar to the subcutaneous fat and also to the bone marrow fat. And in the T1 weighted image, lipoma will be bright, while in the STEER images, lipoma will be dark. And this is the synovial effusion, which is bright in the T2 weighted image. But if you see a mass made of fat within the joint, but this mass is branching like this, then you call this lipoma arborescens. The previous one is known as synovial lipoma, not lipoma arborescens. But if you see branching features like this, and you consider lipoma arborescens. This is a fatty vellus synovial projections. This is an example, and you see the projections of this fat containing lesion within the anterior compartment of the knee in the T1 weighted image and in the T2 weighted image. In both bulk sequences, the lesion will be similar to the subcutaneous fat. This is a classic case of lipoma arborescens. You see the branching feature of the fatty mass, which follows the signal intensity of the subcutaneous fat as well as the bone marrow fat. Also, you see a significant amount of synovial fluid, which will be dark in the T1 and bright in the T2 and the stair images. Another case of lipoma arborescens, we see the branching feature of the fatty mass within the joint and the signal intensity of the lesion, which simulates that of the fat. Also, you may appreciate the presence of lipoma and also lipoma arborescens within the joint in the axial images, because in the axial images you are able to see the borders of the synovium, and it's easy for you to see that these fatty projections are contained within the synovium itself. This is a lipoma arborescens, T1 and T2 weighted images, and this is the axial image where you can see that the fatty masses are confined within the borders of the synovium. Synovial sarcoma is a malignant lesion which arises from the synovium, and this mass will have no MR specific features. It is an infiltrating lesion, will show low signal in the T1, high signal in the T2, and the heterogeneous post-contrast enhancement. This is an example. You see this infiltrating lesion in the infrapatellar region, and it shows high signal in the T2 weighted images, and it will enhance after injection of contrast media. Actually, I will discuss the issues of synovial pathology in full details when I am discussing the arthropathies affecting the joints all over the body. Then the plica is a band of synovial thickening coursing through the synovial spaces. The most common one is located suprapatellar. This is an example. This is the patella, and this is a band of synovium crossing above the patella. Of course, you cannot see the synovial plica unless there is synovial effusion. Then you look in the T2 weighted images, and you can see a band like this. This is known as suprapatellar plica. The next common is the medial plica. The less common is infrapatellar plica, which is located along the course of the anterior cruciate ligament. This is the anterior cruciate ligament, and this is the infrapatellar plica. This is its side, and so many times you cannot appreciate its existence because you consider it as a part of the ACL. The rarest one is the lateral plica. And here you can see this is the patella, the medial articular surface, and this is medial plica. Also, you see the suprapatellar plica as a band crossing through the synovial space in the suprapatellar area. This is the medial plica, the medial articular surface of the patella, and the synovial band crossing the fluid. And also at the level of the medial meniscus, you can see a band crossing the joint representing the medial synovial plica. Finally, we will discuss some of the osteochondral lesions and bone marrow pathology, including the chondral and osteochondral defects, osteochondritis dissecans, bone marrow edema, residual red marrow, migratory osteoporosis, bone marrow infarctions, and of course the bone tumors will be discussed in full details in the lecture specified for imaging of bone tumors. And chondral defect is the defect in the articular cartilage. And as I have said, if you are interested in the evaluation of the articular cartilage, then the best way is to have the specific bulk sequence for the articular cartilage, which is known as magnetization transfer. then you are able to see the full thickness of the cartilage and if there is any defects within the cartilage. And also you can see defects in the articular cartilage of the patella in early stages of chondromalacia patella before affecting the bone. And these are multiple defects within the articular cartilage of the patella. But if the defect affects the cartilage as well as the underlying bone, we call this osteochondral ulcer. And this osteochondral ulcer will appear like this in the T1 weighted image, and in the T2 weighted image it shows some brightness due to the presence of bone marrow edema. Sometimes osteochondral ulcers are surrounded by significant bone marrow edema, as you can see here. This is an osteochondral ulcer, and you can see the edematous changes in the medial femoral condyle. And this is also an example of an osteochondral ulcer in the anterior aspect of the femoral condyle. Osteochondritis dissecans is an avascular necrosis occurring commonly in the medial femoral condyle, and it will result in a localized area of bone necrosis, which will later on separate from the mother bone. Then osteochondritis dissecans can be seen in the plain film, as you can see here. This is the osteochondral fragment, and this is the separation line, as you can see. But it is appreciated very well in the CT scan and also in the MRI. And considering the values of MRI, you should evaluate the possibility of unstable fragment, meaning that the fragment is liable to move from its site inside the joint, forming a loose body which may result in locking of the knee. These are the criteria of unstable fragment. Number 1, if the fragment is larger than 1 centimeter. Number 2, if there is fluid at the fragment base. Number 3, cystic changes in the donor site. Number 4, if you inject contrast, you may get enhancement of the separation line. And this is an osteochondritis dissecans in the lateral femoral condyle. You cannot see the fragment. Each site is replaced by fluid signal, and the fragment has moved from each side. Bone marrow edema or bone marrow contusion secondary to trauma is just accumulation of water within the bone marrow, resulting in low signal in the T1 and high signal in the T2, similar to the edema that you have seen in cases of traumatic rupture of the ACL, for example. And this is bone marrow edema, or what is known as kissing contusions, which are located in the lateral aspect of the knee. And you remember the intimate relation of these contusions to the rupture of the ACL. This is high signal in the tibia, high signal in the femur, at the level of the lateral meniscus. And if you look for this example, you cannot see any abnormality in the gradient image. But in the T1 weighted image, you see low signal. In the T2, you see a high signal. And in the stair image, you see extensive bone marrow edema of the femoral condyle. In absence of a known case of known history of trauma, then you can diagnose this as migratory osteoporosis, which means that there is extensive bone marrow edema without a history of trauma. And this is commonly seen in the hip, as I will discuss in the lecture of the imaging of the hip joint, but it can be seen in the knee and in the ankle as well. And from its name is migratory osteoporosis, meaning that it may affect one joint, then migrate to another joint. But you know that this disease is a self-limiting disease, and it may resolve spontaneously within 6 to 8 months. The etiology of this pathology is not known, but the diagnosis is easy, especially in the hip, where you can identify extensive bone marrow edema in in the femoral head and the neck, as I will explain. But here you can see extensive bone marrow edema in the lateral femoral condyle. Bone infarctions are due to ischemia of the bone marrow within the metaphysis or the diaphysis. And many books usually relate the appearance of bone infarctions within the medullary cavity of the long bones with the Chinese letters. Then they always say that these infarctions may simulate the Chinese letters. But it's easy diagnosis whenever you see this particular appearance, which is an area of abnormal signal intensity within the medulla of the long bone, and the margin of the lesion is formed of two lines. One is dark and one is bright. The appearance of each line will depend on the pulse sequence, and the common appearance is seen in the T2 weighted image, where the bright line is outside and the dark line is inside. Of course, you know that there are too many causes for ischemic necrosis of the bone, starting from idiopathic to trauma to corticosteroids to many systemic diseases and collagen diseases, and here is the list you can look at it. This is the appearance of bone infarction by CT. You see sclerotic lesion within the medulla, and this is by MRI, typical appearance by MRI. And this is also an example of typical appearance of bone infarction within the medulla of the proximal tibia with the lines I have mentioned. Also, you remember that bone infarctions may not be seen in the plain X-ray. And you see this is an extensive case of bone infarctions that are not seen in the plain X-ray, but they may be identified by bone scan and are easily appreciated in MR imaging, showing the typical appearance of irregular shaped lesions within the medullary cavity of the long bones. Actually, as I have said, I will not mention anything about the bone tumors unless in the except in the lecture of bone tumors. But this lesion I like to mention here, which is an enchondroma in the distal part of the femur. Why I mention this particular lesion in this area? Because many times the patient is coming for MRI of the knee for pain, trauma, or any specific complaint. Then the MRI of the knee will show this lesion incidentally. You see in the plain X-ray some bone sclerosis. In the MRI, you see low signal lesion with internal dark foci of calcium. In the T2 weighted image, the lesion will be bright with the sclerotic margin and the internal foci of calcification. Then the radiologist will leave the whole evaluation of the knee and will concentrate on this particular lesion, which is an incidental finding, and starts to describe it in full details, considering the signal, considering the length and the width, and finally it may as I see frequently in the reports, it may recommend the lesion to be biopsied either by CT guided or by surgical biopsy. I want to say that this lesion is an incidental finding in many cases and is not responsible for the patient complaint. Then you may mention this lesion and you say this is an enchondroma, which is an incidental finding, and look for the rest of the knee. Evaluate the meniscus, evaluate the cruciate, look at the collateral ligaments, look at the patellar retinacular, look at any of the lesions I have mentioned, but do not concentrate on this lesion and do not recommend the lesion to be biopsied. Finally, you may get a patient with evident pain in the knee. And the result of MRI is coming as normal. If this is the case, I would like from you to re-examine these particular areas. Number one, look for the posterior horn of the medial meniscus. Sometimes this horn is irregular. As you can see, the contour is irregular, and you may pass this as artifact, but this is meniscal contusion. This is one of the causes of pain that may be overlooked during interpretation. The second issue is to look for meniscocapsular separation. You can see that the medial meniscus posterior horn is good, but it is away from the capsule, and more importantly, it is separated from the capsule by fluid signal, which means meniscocapsular separation. And sometimes some clinicians may contribute pain to the presence of plica. Then, if you want to finish your report about the knee joint, you can have a look for the presence of patellar plica, suprapatellar plica, or medial plica. Then you may mention in the report. Thank you very much. Alhamdulillah Rabbil Alameen. والصلاة والسلام على سيدنا محمد وعلى آله وصحبه وسلم.